that indeed was a good presentation. I think we clap harder. See the history. Fine, this is okay. Fine, this is okay too. There's lots of spelling mistakes, so you guys are more accustomed to WhatsApp stuff. That's the problem. The language is gone for a toss. There's very obvious mistakes that you make when you're sending messages across. It should not happen. And I know there is a big pressure amongst PA group to send messages very, very quickly. Lots of mistakes. And this becomes a part of your life when you start writing English the wrong way. It's a language at the end of the day. And unfortunately, the reading of books has disappeared, so you don't get to know also what it is meaning. It's not incompetency, it's incompetence. And in many words, junction is not that junction. So I know it will be acceptable when it comes on your mobile and you're happy. That's not what you should be learning. Well, then this was very nicely taken care of. I think you did reasonably well about the history. So progress, there are many mistakes, so they are glaring right here. On the medial side of the left hand shoulder, this actually the patient won't be able to tell you. So all you have to say on the lower part of the limb. The medial side will be very difficult for the patient to tell you. And if the patient can tell you medial side, might as well tell you the gauges area. So that's actually finishing it off. The patient has dark blackish discoloration in the lower part or whatever, the leg, or in the leg where, the lower part of the leg, somewhere that way, that's how it's described. There's a history of watery discharge that takes care of it, and it's not as shaded bleeding is there. The bleeding is important to make sure that it is not an arterial disease, although you must understand that most arterial diseases will lead to ischemia rather than bleeding. So an ischemic limb doesn't bleed. It's a venous limb that usually bleeds. Typical of a venous bleeding is it will become worse of hanging down. You lift it up, bleeding disappears. Therefore, there is no use of tourniquets or any pressure bandages above the bleeder in a varicose vein bleed. The management of a varicose vein bleed is limb up and crepe bandage. Vein is fine. If this was nicely done. Remember there are three types of claudication. When you talk about claudication, it is neurogenic, arterial, and venous. And when you talk about claudication, you should somewhere make it apparent that this is arterial, venous, and neurogenic. How do you differentiate the three? Arterial would come on exercise, because as you need oxygen, the pain would appear. It's the same thing as angina pectoris. It will happen when activity is increased. That's why you do the treadmill and other things. Okay. Abdominal angina, when you take meals, pain appears. So arterial claudication would be related to activity. Venous will be related to lack of activity, because actually there will be accumulation when you are standing. And it will be relieved on lifting the limb. How is the arterial claudication reduced or relieved? By taking rest initially until it becomes a rest pain, which is a neurological pain again. The third is the neurogenic claudication. In venous claudication, you also have the edema of the limb because of the venous blockage. In addition to the edema of the limb, you also have changes in the skin of the limb, which will be in the form of what you normally call as lipodermatosclerosis. Exactly, lipodermatosclerosis. That is no rocket science, it's the same thing. The blood oozing out of the vein, collecting in the subcutaneous tissue, breaking down into hemocentrin, etc., and blackish discoloration, then hypoxia of the skin and ulceration. That's venous. Arterial is cutting off the supply, so it will be a dried up ulcer, which is got punched out edges and it is towards the farthest part of the limb. You don't have an arterial ulcer in the thigh when the rest of the limb is fine, which makes sense because if I cut off the water supply to the city, it's the last part of the city where the water won't reach, and that's where you have somebody thirsty. Same thing applies here. Neurogenic claudication is a very different claudication altogether. Actually, it's not a true claudication, but it's grouped as claudication. Here, what does the character say? The pain is every pain is induced by exercise.
Relieved on exercise.
This is relieved on exercise. And the usual cause is lumbar canal stenosis, and sometimes the slip disc, which I talked to you. Now these are three claudications. Bring them in your history. Artlita, no history of night cramps. What are night cramps?
Which makes us wake up.
Louder, louder.
Which makes us wake up at night.
So what does it mean actually? What is happening?
Blood
Now,
decrease.
Arterial claudication when the patient is working or throughout the day and during the night when the patient tries to rest, all due to the excessive working or is the pain
cardiac
in the
output
legs.
is lowest in the night. Simple question, simple answer. The heart is not pumping as much as it does in the daytime. And also the gravity helps in the daytime. I don't think that helps, but heart is pumping. The cardiac output is at its lowest in the night. Is that okay? So that's a night cramp. Swelling in the calf region, fever, prolonged immobilization, etc. You have the lights on. History of trauma is important. Why? Because trauma can bring attention to ischemia, or trauma may lead to all lights, whichever light you can think of. Now, if you know of trauma-related ischemia, arterial injury can happen in trauma. So that can be a factor. Then you must find out that such a patient is working in some factory where there are vibrating tools. Those vibrating tools lead to Raynaud's phenomenon or associated arterial or venous disorders. So you take that history, that will fetch you a mark extra. Prolonged immobilization, very smartly taken history because that will exclude deep vein thrombosis. But don't just try to exclude deep vein thrombosis, exclude the actual problem also. So you should find out prolonged standing and how long is prolonged for him. Then what did it do to cause a venous edema, that is edema in the limb, etc. etc. Now, you got away by mentioning, so you can speak it out. Diabetes is never a past history. I cry horse every time. Most people do this mistake all across. Diabetes is diabetes. It's a comorbidity, mention it as a comorbidity and don't bother about it. Since you mentioned patient is a known case of diabetes mellitus, the sentence does it for me and I'm not a bureaucrat, so I'm not bothered really write it, as long as you can qualify what you said. Patient was diagnosed for infertility 15 years ago. It is relevant and in a male it would have been even more relevant. Why? Clavishes loudly.
Cleric syndrome.
What is that?
Aortoiliac junction, there is blockage. So because of that, there is
Decreased blood supply.
paralysis of L1 nerve, and there is ischemia of the whole leg.
That's wrong.
Iliopfemoral artery.
It's a saddle thrombus. The common iliac disease. There is no such thing as L1. L1 would be higher up, right? That is for importance, which happens. Mostly the claudication for saddle thrombus is gluteal, and they have a block at the bifurcation of descending airway. Now, impotence they explain through both the L1, which is what you're trying to say, there is sympathetic L1, and also the muscular activity between them. First history was perfect, I couldn't have added anything. Next history is fine. Treatment is fine. I was telling the history was very good. I've just added a few things. Now, general physical examination was also nicely done. Remember, I think I must have told you sometime, in a patient who's got limb problem, fracture, ischemic limb, you cannot you cannot count for performance status because he can't walk. You would call it bedridden, which means performance status is less than 60 while he's fit. If you break his leg, he can't move. And then you can say he didn't move, so performance status is less than 60. That's being foolish. So it doesn't work here. There are places where performance status may not be relevant. I'm not saying it's wrong to take it, but you can always qualify by saying patient has a morbidity in the form of pain in the limb. The moving around is history. Nutritional status and BMI were rightly mentioned. And I'm glad you mentioned about no vitamin differences. It is important to mention. This is fine, and there is nothing like MM of SG, millimeters of mercury. And it takes the same time to say. Maybe that is if you're too much into that typo thing on the WhatsApp. I mean, that's a serious disease. Don't get into that. Learn to write your English properly. That's where the problem starts. Clinical evidence of non-pitting edema in both feet. I'll ask you what is that. You should be the moment you say non-pitting pedal edema, don't say pitting edema of the non-pitting edema of the feet. That's called pedal edema. Pedal edema is edema of the feet. This we'll have to explain. Now, I think you did the right thing by starting with the less diseased limb. Which is the less diseased one?
The right.
You did the wrong thing by starting with the left sided limb.
Normal.
I've always taught this. You always describe the normal side first.
Yes.
So that may make more sense. Always, anything which is paired in the body, whether it's lips, eyes, anything, describe the normal side first. For many reasons, but most importantly, to find out which one is the normal side, and therefore which one is the normal. So how was the left one? Good. No need you want to answer. How was the left one? He has one. See, this was affected. Now what that does is, I wanted it deliberately to happen. The one advantage I told you of examining the normal side is that you know which is the abnormal side or a relatively more abnormal side. Getting right. Sorry. Now the right is relatively less disease. That's what you're saying. So we'll describe the right one first, so that you can comment on them as much as you want to. That's one. Number two, you have to describe both the limbs. You forgot the other limb. You will forget it. So in the process of, therefore it is better that you start with the normal side first. It's very common, say, in breasts, to miss the normal side or the other side of the contralateral breast. There could be a finding there. So therefore describe the right one first. The rest of the steps are all fine. Attitude, when you say inverted champagne bottle appearance, that is very late in the disease. So don't be obsessed at mentioning it. More than that, was important to mention that there are ulcers and discoloration that are confined to the gaiters area. What is a gaiter, Rohit? You don't have to get up. Does that take that long? Gaiter?
Between the ankle and the knee.
South.
It's the most common site for ulcer.
What is gaiter?
Where the middle
It
measure
is
is.
used to wear at the places like in snow or at
I told jungle, snakes. So they cover their knees up, soldiers, when they were wearing shorts. Or even if they wear trousers. They need to cover the ankle and that area of the snake bite. That's the most common site. The area was, this is gaiter. That where you apply it is called gaiter's area. That's an area where there is no subcutaneous tissue. Shin of tibia. The veins, they dilate and they ooze. And the skin not being supported by the subcutaneous tissue gives way and ulcer forms. Most common site for the disease. This is not written in your books, and certainly not in Guatemala. Or if they're telling you, they'll tell you wrongly. Be careful what they're doing. There are also my notes floating around, I keep saying this. But they say different things. Notes don't have what I've been speaking. Anything happen. Be careful. Pre-heat ulcers in the medial aspect of ankle, well described. And there is no problem with your presentation, let me tell you. It any day is a 60 plus presentation, which is not too bad. But if you can improve, it is always better. And attitude, this champagne bottle disappears for the time being. Skin hyperpigmented patches in the medial aspect and dorsal of foot. Affected venous system, grade 7 short, you're smart at that. You didn't waste time, vein goes from there. Describe it and leave it closed for the examiner to ask you, how do you notice great sephnous system and how do you notice some short sephnous system? You would say medial side, lateral side, posterior side, etc. External involvement, dominant dorsal, this is fine. Some varicose communicating veins also seen, this is fine. Blowouts blowout is not one, the blowouts. So you involved here, which is correct. So blowouts also seen. Who is saying also seen? Blowout seen. You're not telling us a story here. Pre-heal ulcers seen in the medial aspect of ankle. Again, this entire thing, the gaiters area, I'll just sum it up for you. Gaiters area has pigmented skin with 3 or 4 ulcers, of which 2 are healed. The visible dilated veins affecting the great and short septal system. Okay? Now, the cuff impulse, where is absent? Oh, cuff impulse could be for hernia, could be for Valsalva, could be at the, so cuff impulse could not be appreciated at the sternofemoral junction. And you can highlight it because that indicates sternofemoral incompetence. Now right leg. This is the less diseased one. You should have described this first. Otherwise, it's fine. Skin, etc., etc. What you are missing in limb. One is aptitude, which they described. Apparent lengthening and shortening, which they did not describe. Visible skin changes, which they described. Ulcers, etc., they described. Dilated veins, they described. Brittle nails or features of chronic limb ischemia, which they did not describe. Then the deformities of visible deformities, they did not describe. Arches of the foot, because varicose veins lead to equine deformity. So arches get exaggerated. They did not describe. Movements in the joints, they did not describe. And finally, in the examination of the varicose veins, vascular system of any kind, you don't examine the abdomen, your examination is incomplete because you need to examine for a lump in the abdomen which would be sitting on the common iliac vein and producing bilateral varicosities. 2, you could be missing an aneurysm of the aorta in an arterial disease. 3, you could be missing a calcified aorta, which means a hardened calcified aorta in a atherosclerosis. 4, you could be missing an abdominal lump due to aneurysm of aorta. You will be missing a hell of a lot. The abdominal examination becomes necessary. Necessary is wrong, mandatory. Examination of spine is necessary because as they develop this problem, they walk with a particular posture. Usually they could have a tilted spine, scoliosis, which is functional, but it is there. You've got to describe that. And the arches, I can see they are flattened on the limb that you are showing. Or they are exaggerated on the limb you are showing here. I would not know which one is normal. Therefore, I would like to see the one which is normal. Are you getting my point? For any statement that I make about X or Y, it is based on the statement I make about A or B. So therefore, normal is important. Palpation. I think afebrile to touch. Afebrile is a patient. Afebrile means no fever. The local temperature is normal. Limbs are not afebrile. The patient is fine. Limb has fever. Doesn't happen. Afebrile to touch, no tenderness along this and this side. Cup and pulse, negative, this is fine. This was okay. How do you describe the Trendelenburg 1, Trendelenburg 2, modified Perkins test.
So
The rest of the tests are useless. These are the only 3 tests that you need to do.
sir, first we tell patient to lie down,
They should lie down.
and we will raise the limb on which we are testing the particular test. We will raise for some level, and we will milk for the venous system, and then we will tie an tourniquet or a polyester just below the saphenofemoral junction.
But you've not found it.
Sir, it is.
No,
Sir,
no, no, no.
we have to mark first.
So it's wrong. Redo it.
Sir, first we.
It's done. Done.
So if you're going to elevate the limb,
First we will mark this.
So let's start with what you do first. You need to find out where the saphenofemoral junction is.
Yes.
And for that, what do you do? The same old jiggly pokery which I told you in the OPD that you can find the easily, but there is a drill, so you need to describe it. How do you do it?
Frog leap position.
3.5 centimeter below the pubic.
So frog leap position. So frog leapfrog position.
Leapfrog position in which we take the heel of the one limb and take up to the knee of the other limb, and then we find.
Oh, which limb? The one where you're looking for.
Yes, which we are looking for. We are looking for the right. We take the right limb, take the heel of the right limb, take it toward the knee of the other limb, and we look for the pubic tubercle felt in the mid.
Adductor longus. We palpate along the adductor longus.
The adductor longus stands out. Sit down.
And we
Place it up to the pubic tubercle. And from there you measure 4 centimeters
down and laterally.
Mark it. I wanted this mistake to happen, so then you remember it. I hope you remember it. If after this you don't remember it, go and leave that position yourself. Once you found the saphenofemoral junction, you mark it. Now you lift the limb up. It's very simple and people make it very complicated, so I'll tell you in simple words. Lift up the limb, empty the veins. Veins are empty. Now put your thumb on the saphenofemoral junction, or you can apply a tourniquet. The problem with tourniquet is how tight should be the tourniquet, how tight is tight. You need to put it in such a way that it allows only one finger, because you may occlude the deep vein also, that's not fair. And you put a knot, you don't put a knot, so what do? Once you take a rope, then tuck it here, so that you can just pull it and it opens. It is to be seen, to be known, to be understood, because everything cannot be learned from YouTube or from watching movies. It will have to be done also. So virtual reality is no reality. So physically, learn to do it. So once you find that and you've occluded it, you make the patient stand up. Now what are you occluding? Saphenofemoral junction. So what are you not occluded? Perforators. So it's common sense that deep circulation, deep blood would come towards surface. So veins will gradually start filling up. Because perforators are
incompetent.
That is, perforators are incompetent. They will start filling up now. Then your book says slowly. How do you know how slow is slow? So they just start welling up gradually. Now you found out there is a perforator problem. We just need to find out one more thing. It's a saphenofemoral junction also incompetent. So first part of the test is called T1. T1 done. For T2, you will watch the great saphenous vein where it was marked and release the thumb and see the blood fills in suddenly. That would be saphenofemoral junction. And for me that is actually over. T1, T2 is over. Clear to all?
Yes, sir.
Yes or no?
Yes, sir.
Now the next thing is, we need to find out the deep vein is blocked or not. I will come back. Deep vein is blocked or not. Now it depends on what? Superficial veins are draining into deep veins through perforators. So I occlude one of them and then test. I can only occlude the superficial veins. So what do? I will not empty the veins. That's the only difference. I'll not
Empty the veins.
but I'll apply the tool
Yes, sir. As the
so
patient.
that I don't allow the superficial system to empty outside. And then I'll make the patient do some tiptoeing. know tiptoe?
Yes, sir.
I'll ask.
So then the toes, basically toes to walk. We are making the patient walk.
Just jumping on the same position with on the toes, so that the calf.
But tiptoeing is, you have shocked absolutely.
So it's the extensive flexing of the.
Typical Spanish dancer. You can't actually, alright, jump on the toes. You'll understand that's enough, that's fine. The earlier days, we were asking the patient to do some walking.
Hmm.
The patient walks, exerts, but the trouble was in the exam, the patient will just walk away. This is fed up. One has seen, then the second has seen, then the third has seen. So the patient was sent for a walk, he never came back. Therefore the tiptoeing came in. Tiptoeing is you do. Soldiers also do that.
Yes, sir.
Standing in one place. You just have to make the calf muscles function.
Hmm.
As the calf muscles function, the deep vein has to function. If the deep vein is patent, it will drain and the superficial system will collapse. While if it is blocked, the venous drainage of the calf would suffer. The patient will have severe pain, and these veins will become more prominent. Isn't that simple?
Yes, sir.
So one should be surprised. Now there is one called modified Perthes where they apply a great bandage, which is a waste of time, because this is all that you need to find out. T1, and what are you saying about T2? Yes, who was raised? What was the problem?
So after we do, even if the blood vessel get filled, then we have to.
The great septus vein can't get filled, no? How will great septus fill? Perforators are filling the short septum, lower system, no? If the Hunterian perforator is also incompetent, then you won't get a case. Sit down. That's too complicated. And you won't get it. If you're pressing on the saphenofemoral junction, all you're doing is you're preventing the femoral vein blood to come into great septum vein. That's it. And then I release it, and you're not taking 2 hours to do that. It'll take a little while more. That's it. So first was a test which is happening. You don't do anything. You just block the saphenofemoral junction, and you look at the veins which are below. If they drain, fine. If there's perforator incompetence, it will increase. If there's no perforator incompetence, it will decrease.
So what does T2 plus significant if we release the occlusion, the blood will gush. So what the T2 test would try to discriminate between?
No, it is discriminating between nobody. It is just to find out if the saphenofemoral junction is incompetent. See, if I press your great saphenofemoral junction and I release it, nothing would happen. Why should anything happen? Deep vein is deep vein, blood flows towards it. But if it is flowing backwards, how would I test? You got it? Got it? What did I say?
The vein is filling into the
You got it. Now, so we have done the Trendelenburg 1, Trendelenburg 2, and Perthes test, and call it modified Perthes if you put the gray bandage in. It is no longer recommended that you do so much of walking that the patient has bursting pain, which will happen. It's enough to see that these superficial veins are collapsing. You must have seen, if you stand for a long time, your limbs start hurting. If you walk and you run, it starts getting relieved because the lactic acid is washed out and the calves push the deep blood up and the superficial is cleared out. That's why exercise is better than standing still. If you don't get weightlifters or runners getting varicose veins, it's usually those who are standing and standing for too long. Weightlifters may get it if they otherwise don't have a strong tone. They're carrying the weights. This can happen in those cases, otherwise it doesn't happen. That's about these tests, and then we move to, it's rightly described, so there's nothing wrong with that. The multiple tunicate test is done if you want to really find out where is the perforator. Between the you tie tunicates and in between you see where there is a filling up, so that's where the perforator is. There are 4 or 5 of them, void and docket, and the names are not important. There's one just above the medial malleolus, one just below the knee, and two in between the two. And there's one above the knee, which is a arterial perforator, which is in the adductor canal. That's about it all. These days, all over the world, these tests are more or less abandoned because the examination involves, I examine for MRCS regularly. For varicose vein, we give the handheld Doppler to the students, bring their own handheld Doppler and they make a diagnosis, because there's no point in doing this test when you can find out with a simple handheld Doppler and more accurately, it's more sensitive. This examination is very subjective, and the sensitivity of these examinations, like most clinical examinations, less than 50%. So why was the sensitivity higher earlier? Because they were always doing this. You do it all the time. That percussion on sternum was not a bad thing for somebody who has done millions of those, because he can differentiate between the feel that he has. I was describing yesterday. The test is not obsolete. The times have changed. It won't be as relevant because you do once in a month, then you won't be able to appreciate that. So you can apply this and you can actually find out that they've done it all right. And it's a live demonstration of what should be done. Nicely done. Now your abdomen would have come in here and brew is fine, but examine the abdomen always, examine the spine always. If you do that, it's a complete examination. Now when you're giving a diagnosis, don't give the symptoms. Rest is fine. Don't give the name. A 50-year lady
With left ankle.
with bilateral chronic venous insufficiency, left more than right, with clinical stage CS5, BP, etc. etc. Now why this clinical staging system has come into place? You will keep describing till the cows come home. She has an ulcer on the lateral side, she has an ulcer on the middle, she has an ulcer below, she has an ulcer above, veins are congested here, they are dilated there, it goes on. So we will spend the whole day talking about this patient's diagnosis. When are you going to treat? So they came out with the CAP system, which you can read. This class is not about CAP to be remembered, but you should know it. And if you give a CAP classification, the examiner is happy because that would mean everything that you're saying. So I would describe it as a bilateral varicose veins with left being more than right. And there are features of chronic venous insufficiency, so I'll be very easily saying CVI. And when I say chronic venous insufficiency, the right limb doesn't have it because they're just varicose veins there right now. What is a varicose vein? It's a dilated and tortuous vein. Why is it tortuous? Because it's elongated. The limb doesn't increase in size. Vein is increasing. So like a snake, it has to accommodate itself like a tortuity. And dilated because since it is not going anywhere, it has to go this way. The features of chronic venous insufficiency that you got here are very obvious. How do you proceed now? Investigations to confirm the diagnosis, to support the diagnosis and to treat the patient. Don't say stage, that is easier. Is that okay? If there was somebody who was staging a hernia today, you can't do that. Now, once you say, I am getting a diagnosis clinically, it is generally assumed all over the world that you've got a handheld Doppler also. You don't have it. If you had it, you would have made a more accurate diagnosis. And when you're doing the Doppler, which is the way to, the Duplex scan is the way to confirm your diagnosis, you try to look for the venous filling, perforators, and staphnofemoral incompetence. That's why I stopped you there. I was not making fun of you. Try to understand. I wanted to come at this point so that now I can answer. We do a maneuver called Valsalva maneuver and exaggerate the leak back on a Doppler. So we are able to comment on staphnofemoral junction incompetence even better. So if you had the Doppler to begin with, you could have done it with the clinical examination. And like I have taught you in thyroid, in breast, and in abdomen and elsewhere, ultrasound is an extension of clinical examination now. Ultrasound is a stethoscope of a surgeon. So you would do an ultrasound yourself all the time. Okay? Like we do in the OT, you must have seen, we find out our lump in the breast. We don't call a radiologist for that because in any case it's too simple. So you can always do it. Once you've done the ultrasound Doppler, we have found out about the deep vein, superficial vein,
perforators, the affected limb, continental limb, and also the common eyelids. Then you know which part of the venous system is affected. Once you know that, treatment becomes straightforward. When you describe the treatment, I am winding it up. We do need investigations to look at the limb also. If there is an ulcer, get an X-ray limb done. And whenever you do an X-ray of a limb, follow the rule of two. If you're taught in orthopedics, it's good. Otherwise, I'm teaching you just now. 2 sides, 2 limbs, 2 views, and 2 joints. If you don't take the joints, you won't know if the bone is rotated. 2 views because you may miss the displacement in a particular axis. 2 sides because in children, the epiphysis may not have joint. You can call that a fracture unless you compare to the other side. Same thing, comparing. Do the X-ray to exclude osteomyelitis. The management of the patient, of the limb, of the ulcers, of the patient, either diabetic, management of diabetes. Lifestyle changes. If it's a sedentary, long-standing kind of a workup, advise him to walk around, exercise. Stockings, the compression stockings that are graduated now. Don't just put on a stocking. Graduated so that the pressure at different levels is
Different.
is kind of gradually increasing. It should be so tight that it presses on the deep vein. Suppose the deep vein is blocked, we cannot do surgery. The absolute contraindication to treating superficial veins or the varicose veins is deep vein
thrombosis.
Rest, management of the patient, as I told you, nutrition, etc. Then the limb, offloading. Advice regarding hygiene. Moistening the limb. It's cracking. One thing was missing which I forgot. Never miss in the limb examination of the arterial system, neurological system. Because the limb is, I have already taught this in a soft tissue sarcoma case. Examine the artery, the veins, the nerves, the joints, the muscles. It's very rare is it a purely venous. And finally, the treatment of the varicose veins. If you are treating by surgery, then there is an operation called loudly Trendelenburg's operation. Write it down. We do what?
Stress ligation and stripping of the saphenous vein.
So that's the wrong answer. You didn't write. I know you're too clever now. You don't have to cut. Write and cut. Remember. Trendelenburg operation is obsolete now. This operation involved not stripping the vein. So they would just disconnect and leave it. Now where would be the problem? The Hunterian perforator will come and fill it. It is the Hunterian perforator which makes it mandatory to strip. And therefore they don't strip beyond the knee because Hunterian perforator is over there. If you go beyond that, you will damage the femoral nerve or saphenous nerve, when you're stripping. So up to knee, transection of the great saphenous vein after ligating with 3 tributaries and then stripping. That's the operation, and it is not called Trendelenburg operation. So venous stripping. You have some non-operative, non-surgical procedures now, which include foam therapy, more or less going out of use, radiofrequency ablation, just know the names. Don't bother to write too much about that. Which is nothing. You empty the vein, put in some sclerosant, which produces a non-infective inflammation, fibrosis, vein blocked. Or put in foam, same thing. Or put in a radiofrequency wire and keep blocking from above down. You block from below up, you won't be able to go.
Yes, sir.
The monkey would start from here. Let's fire, I can see. But then you won't go anywhere. Farthest you go, and then you start coming. He heats up the skin. You need to keep the skin moist at the temperature. Last question, when the venous bleed happens, the management is not tourniquet. If you don't do anything, it will stop, but not tourniquet. Tourniquet would make it worse. So we elevate the limb, apply the compression, stockings or bandage. They also will just protocol workshop. Any question quickly? Any burning question? Anybody? Is that clear?
Yes, sir.
That's a varicose vein. well presented. I think they deserve an applause before I leave.